I'll share a little bit of my background while I'm sharing my screen. So while I was working as a, um, let's see, while I was working on my graduate program, uh, spasticity was a qualifying condition for medical cannabis, and that was my part of my research as my for my PhD. And I was a pharmacist, and you have to be a pharmacist in Minnesota to dispense cannabis. So I thought, well, this will be a great way to get to know my research population on a more clinical level, and it'll supplement my stipend a little bit. So that's kind of was my first exposure into the cannabis world. And I quickly learned the paucity of research surrounding that. So that's was my launch pad to learn more about the pharmacology, the therapeutics, the different risks, and the research opportunities, which is what we'll talk about today. So quick, some of my disclosures are mostly on grant support and product donation from CytoCBD and the Pancreas Cancer Research Task Force. And just from the nature of cannabinoids, this presentation will contain discussions of unapproved drug uses. This presentation will go over quickly the endocannabinoid system, a little bit on the botany and the policies throughout the US. And we'll dive into the therapeutic applications and risks of THC and CBD and identify some important considerations if patients are interested in pursuing cannabis therapies. So the endocannabinoid system is in all vertebrate animals, and it's a major player in the homeostatic system. So it functions in relax, eat, sleep, forget, and protect. So homeostatic roles in hunger and feeding and energy, neuroplasticity, neuroprotection, pain, autonomic tone, immune response, connective tissue repair, and human behavior. And within the endocannabinoid system, there's three main components: the receptors, the actual cannabinoids, and then the enzymes that either synthesize them or degrade them. So the major receptors are cannabinoid receptors 1 and 2, and then there's also some orphan receptors in there. The endogenous cannabinoids that are acting on these receptors are anandamide and 2-arachidonoglycerol, and these endocannabinoids act as retrograde synaptic messengers. So they're released postsynaptically and act presynaptically. And then they're either synthesized or degraded. The major degrading enzymes are FAH and MAGL. So taking a deeper look, and specifically these different endocannabinoids, they can be synthetic, or we can also have phytocannabinoids when we're looking at the exogenous phytocannabinoids. So the endogenous cannabinoids, like I mentioned, are anandamide and 2-arachidonoglycerol. The great thing about these is they're synthesized when and where you need them. So they're synthesized right at the site of action. They're rapidly broken down. So those signals are going to be really quick and really local. There's a number of different phytocannabinoids. There's actually over 120 in the plant. THC and CBD have the most research behind them and are the best understood, which isn't saying much because there's still a lot to be learned about these two compounds. And then Sativex and Epidiolex are plant-derived medications. Sativex isn't approved in the US yet, but it's going through the approval process. Epidiolex is a CBD plant-derived approved product. Then Marinol and Nabilone are synthetic forms of THC. And just by the nature of the exogenous ingestion of these, they're going to have a larger volume of distribution. They're often metabolized by the liver, so they're going more systemically. They're highly distributed throughout the body. So this is going to have a more sustained effect, more off-target effects, and more long-term effects. So looking at the targets and the mechanism of action of these two main phytocannabinoids, there's again CBD and THC. CBD is the major non-intoxicating cannabinoid, and I know a lot of people say CBD is not psychoactive and really caution that language because CBD does have some anxiolytic properties. And so, we do know there's some activity in the brain. So saying it's non-psychoactive isn't entirely accurate. And then on the other hand, there's THC, which is the psychoactive molecule. So specifically for CBD, it's an inverse agonist at those two CB1 and CB2 receptors. It has weak affinity with those receptors, but part of the action at those receptors dampens the psychoactivity of THC. So when used in combination, some of that psychoactivity from THC can be decreased, which could improve its therapeutic applications. There's another number of other targets. There's over 65 receptors that CBD is acting at, but a couple to pull out are some TRP receptors, serotonin receptors, and GPR 55 and 18. And then it's inhibiting the uptake of some of the endogenous endocannabinoids and inhibiting the degradation. So it's making those endogenous cannabinoids more available. And it also inhibits the release of some pro-inflammatory cytokines. On the other side, THC is a partial agonist of CB1 and CB2. So it appears that the mechanism of action is a little bit more straightforward, but there are some off-target effects as well. And then when ingested, there's also an active metabolite, 11-hydroxy-THC, and that's thought to have 4 times the amount of psychoactivity than THC. So when THC is ingested, there's a higher likelihood for psychoactivity. The policies throughout the US have drastically changed over the last decade or so. Right now, there's over 30, I think there's about 35 states that have medicinal cannabis programs, and of those, 15 have recreational programs. Those in kind of a lighter green on this figure are CBD only programs, and those in gray have no policies surrounding cannabinoids. However, cannabis federally is still considered a C1 controlled substance. Hemp, which is a form of cannabis that by legal definition is said to have less than 0.3% THC, is legal. And that's where a lot of the CBD products are derived from. And Epidiolex, that FDA approved CBD formulation, is a C4. Interesting to note, though, in these medicinal states, a handful of them mandate pharmacist involvement in the medicinal program at some level or another. So it's just an interesting model as Wisconsin considers either medicinal or recreational programs. It's an interesting model to consider. So, as I'm sure a lot of you have heard, there's a number of proposed pharmacologic effects from cannabinoids. I mean, almost everything under the sun is linked, has been linked to a positive effect from cannabinoids. So just pulling out a couple significant ones here, analgesia, that's primarily from THC, and anti-inflammation is primarily from CBD. So an example that we would use in the medical cannabis dispensary is if we had a patient who had Crohn's, for example, they may use CBD or a high CBD or a CBD dominant product. So there still may be some THC in there, but it's CBD dominant. And they may use that chronically, so orally and 2 to 3 times per day to try to control the inflammation from Crohn's. But if this patient had an acute attack, they may have a either sublingual or an inhaled formulation available of a THC dominant product to try to manage that acute pain and have that fast onset of action. So as I kind of alluded, there's a number of different therapeutic applications. I mentioned Crohn's in the last example, but pain, different psychiatric disorders, cancer supportive care is a major application for cannabinoids. Sleep, primarily THC, is used for sleep, migraines, harm reduction has been researched, spastic disorders, so Sativex. That product is approved in a number of different countries for spasticity with multiple sclerosis. A number of neurodegenerative disorders are under research, glaucoma, different skin diseases. We're seeing this pop up in acne products, anti-aging products are containing CBD. The research behind that is a little questionable, but they're on the market nonetheless. Epilepsy, Epidiolex is indicated for a couple different forms of epilepsy, autism, Tourette's, and HIV/AIDS. So there's a lot of different therapeutic applications. This chart really summarizes the evidence behind some of these different therapeutic applications. So specifically for THC, there's the most evidence to use THC for neuropathic pain, cancer supportive care, particularly for peripheral neuropathy or nausea and vomiting, and spasticity. And then where there is a negative sign that may indicate that it could exacerbate that condition. So particularly with high doses of THC, you may experience some paranoia or higher anxiety. For CBD, there's the most evidence for anti-inflammation and improved seizure control. However, particularly with THC, there's a number of different potential adverse effects or potential risks. So for CBD, the main adverse effects are pretty manageable typically: dry mouth, diarrhea depending on the dose, and monitoring liver enzymes because there could be acute hepatic injury. But more looking at THC, there's acute negative effects that can affect attention, short-term memory, balance, and reaction time. On a short term, when a patient uses cannabis, it may increase the heart rate and blood pressure, but with long-term use, it can cause a decreased heart rate and a decreased blood pressure. There's also the risk of angina with cannabis use. And when I say cannabis, I'm referring to THC dominant products or recreational cannabis. Long-term use is associated with more frequent bronchitis episodes and worsening respiratory symptoms, but cessation of cannabis has been shown to improve those respiratory symptoms back to baseline. There are links to testicular cancer. Cannabis hyperemesis syndrome is something that can happen to patients, particularly those that have heavy use, often starting in adolescence. So this is a cyclic form of vomiting that one of the major hallmark symptoms is compulsive bathing, particularly extremely hot showers. As I mentioned, there's kind of that biphasic effect on mood and anxiety. At low doses, it could improve mood, cause a euphoria, and be anti-anxiety, but at high doses, there may be more paranoia and anxiety. There is a dose-dependent association with psychosis and suicidality, and early heavy use is associated with schizophrenia. Tolerance can develop along with dependence, particularly tolerance is associated with the pharmacodynamic effects. There's no evidence of pharmacokinetic tolerance. Some other things to consider if patients do intend to pursue cannabinoid therapies. There's a number of different drug interactions. So THC and CBD are inhibiting a number of different CYP enzymes, which can impact these other drugs. The drugs listed have had studies evaluating them, but there's a number of other hypothetical interactions from these CYP enzymes. But specifically for warfarin, THC and CBD have been shown to increase warfarin levels and therefore increasing INR. THC has been shown to decrease the ethylene levels, and CBD increase clobazam levels. And then there have been some pharmacodynamic interactions, particularly with alcohol, barbiturates, and benzodiazepines have added CNS depressant effects. So kind of summarizing, the safety, particularly with these high THC products, if patients, with either acute psychosis or unstable psychiatric conditions, if they have severe or unstable cardiopulmonary disease, if a patient is pregnant or breastfeeding, or there's a history of substance abuse, they really should not be using cannabinoids. Particularly for pregnancy, heavy cannabis use is associated with reduced neonatal birth weight. And then there's some precautions that these patients, could proceed with caution with using cannabis or steer clear. So these include patients with severe cardiovascular or immunologic liver kidney diseases, any history of arrhythmia, psychiatric disorder, or a familial history of schizophrenia, and if they have had that hyperemesis syndrome in the past, either pediatric or elderly patients. Pediatric for the impact on development, elderly, it would increase the risk of falls, and a more likely have drug interactions in those elderly patients or those with polypharmacy. But if the patient is a candidate for medical cannabis, there's a number of different routes of administration. So inhaled routes of administration, whether that's smoked or vaporized, are going to have the quickest onset of action. They're also going to have the slowest duration of action. But this quick onset of action can lend it to self-titration if needed. We typically recommended that patients wait 15 or so minutes before administering a second inhalation. And then somewhere in between are the oral mucosal or the sublingual routes of administration because of the mixed absorption with the gut and sublingual. So the onset was typically anywhere from 15 minutes to an hour. And the duration we would see would be, 2 to 6 hours typically. And then there's the oral routes of administration. That could be anything from a capsule to an edible. There's a lot of different products out there. Oftentimes, the onset can be as long as 2 hours. So really cautioning patients to wait, take small doses, wait 2 hours, and then if they need an additional dose, and the duration is much longer, so anywhere from 8 to 12 hours. So some things to think about, even if it's a over the counter, for lack of a better term, CBD product, or if a patient is looking into medical cannabis or recreational cannabis. So a lot of, what is in these products that we don't know. Crude cannabis or recreational cannabis may be cheaper, but we're not going to know what's in it. There's a lack of control even in the commercial market. So oftentimes we may not know the cannabis content. There could be potential contaminants, whether that be heavy metals, pesticides, or other pathogens. And we still don't know dosing. It's really been self-titration and monitoring. There's a lot of available routes of administration. The crude forms are often either smoked or using an edible. The pure forms of cannabis, there's inhaled from a vape, oral, topical, sublingual, and rectal. And again, in several states, this is still illegal. And then labeling accuracy, as I alluded to, is a large problem. So, in summary, the endocannabinoid system plays a major role in homeostatic regulation. Although there's over 120 cannabinoids, CBD and THC are the most heavily researched and have the most evidence. There's a lot of different potential therapeutic application for these cannabinoids, but it's really important to weigh the possible risks and the things that we would need to take into consideration if someone did want to pursue cannabinoid therapies are their health risks, what the route of administration is, helping them find an appropriate product, and what the right dosing would be. So I appreciate your attention and time. And if we have, I think we have a couple minutes if you have any questions.
This is Sheila Wykes. I have just an observation. We've seen some of the cannabis hyperemesis happen, and
Mm-hmm.
just on a purely anecdotal basis, we seem to see a greater frequency with those folks that are using the edibles. And then we're
That's
hearing things
interesting.
about their pattern of use of the edibles because no one knows you're doing marijuana. So particularly the gummies are big favorites. And I've
Mm-hmm.
had people talk about, well, yeah, I keep them on my desk and or in my desk, and yeah, I just kind of take one whenever my anxiety bothers me during the day. So you have some use of cannabinoids that you didn't get when you had to roll it. You know what I'm saying? So
Sure.
we have no idea if that's more than anecdotal, but it's what we've seen, including a patient with really severe diabetes who was being frequently hospitalized, ended up with a peg tube and all these things. And when we were able to get her to decrease and then stop the edibles, we stopped the hospitalizations, and that was the big thing that we were doing. So just an interesting sidelight.
Yeah, that's interesting. I would be curious to see if that active metabolite plays a major role in the hyperemesis syndrome because it is only with the oral route of administration through first pass. So I wonder if that plays a role in the development of that hyperemesis syndrome.
That, and are there not receptors in the gut as well, cannabinoid
Hmm.
receptors? And
There
that
are.
act differently than the cannabinoid receptors in the brain, because that was
Hmm.
part about the other thing that we were thinking about with it.
Yeah, that's interesting. But you're right, cessation is the only really method for stopping the hyperemesis syndrome
And that
that
was
I've
years
seen.
worth of work. Yes.
Mhm.
Yes.
Hi, this is David. I was wondering if you have any experience with Delta 8 THC. One of my patients brought it up this week, and I have never heard of it. So I was just wondering if you have any thoughts about it.
Yeah, I haven't looked into that as much, but I've been hearing about it more frequently lately. So I don't have any wisdom to impart, unfortunately. I've heard anecdotally that it doesn't have the same level of psychoactivity, but that's really just anecdotal. I haven't looked into it heavily.